Welcome to the Deep Dive, where we take complex biological systems and really zero in on the essential truths and surprising insights that help you get truly well-informed.
And today, our focus is on one of the body's, well, greatest stabilizers. Those organs quietly managing our fluid chemistry. The kidneys.
Yeah, these two bean-shaped wonders, they're constantly working, aren't they? Filtering your entire blood volume dozens of times every single day.
It's an incredible workload.
And here's the really staggering fact, the one that kind of sets the stage for our deep dive today. The functional units inside your kidneys, the nephrons, they're irreplaceable.
Completely
You
irreplaceable.
start with about 1 million per kidney, maybe a bit less, maybe a bit more. But after age 40, you actually begin losing them. The average rate is about 10% every decade.
10% gone every 10 years.
And that loss is irreversible.
Exactly. It just highlights the incredible value of what you start out with, doesn't it?
It really does.
And that vulnerability, well, it underscores our mission today to really understand the kidney's intricate architecture, its deep involvement in hormonal messaging,
Right.
how we measure its function, especially when it starts declining, and the major diseases that threaten its delicate balance.
So for this deep dive, we've pulled together detailed clinical sources, covering pretty much everything from basic renal structure and physiology right up to advanced diagnostics, pathology, even pharmacology.
We want to give you a complete, but also, a highly digestible picture of this critical system.
Okay, let's dive in. Section 1, the master regulator. You mentioned their scope of work is huge.
It is. If we boil down everything the kidneys accomplish, we can sort of categorize them into 4 core pillars of function.
4 pillars. Okay, what are they?
First, and probably most famously, they filter. They act as this massive sieve, constantly cleaning the blood, removing all the small molecules.
Right, the waste products mostly.
Yeah, mostly waste, but other small things too. Second, they reabsorb and secrete. Now, this is the highly selective part. They need to keep the good stuff.
Like sugar and water.
Exactly. Glucose, water, amino acids, and then actively dump the unneeded substances back into the tubule system for elimination. That's the secretion part.
Okay, filter, then sort.
Then, third pillar, excrete. This is the final step, creating and eliminating urine.
And what I find fascinating is the list of things that should be in that final urine is actually pretty short.
Very short, ideally.
Just urea, uric acid, and creatinine, right?
Yeah.
All products of metabolism.
Correct. If you find anything else significant in there, like blood cells or large amounts of protein, that's almost always an immediate red flag. Something's wrong with the filter.
Got it. Filter, reabsorb, secrete, excrete. What's the 4th pillar?
The 4th pillar is arguably the most crucial for overall survival. Regulate. This covers the minute-by-minute management of the body's fluid balance and ion balance.
So electrolytes.
Yes, making sure essential electrolytes, sodium, potassium, calcium, phosphate, are kept within incredibly tight limits. These are the homeostatic functions, keeping our internal environment stable. Life depends on it.
We tend to think of the kidney mainly as that waste processor, the excretory role. But you mentioned it's a control center too. Let's talk about its endocrine function, because I think that gets overlooked.
Massively overlooked.
Right.
The kidney is far more than just a passive filter. It's an active hormone producer. A really key one it produces is erythropoietin, or EPO.
Ah, EPO. Famous in sports, unfortunately.
Yes, but biologically essential. It signals the bone marrow to produce red blood cells. So if your kidneys fail, you lose your ability to make EPO.
Which is why chronic kidney failure patients almost always have anemia.
Exactly. Severe anemia. It directly links kidney health to your blood's oxygen-carrying capacity.
Okay, so red blood cells. What else does it manage hormonally?
It's also critical for bone health. This links back to our electrolyte regulation point. The kidney performs the final, crucial step in activating vitamin D into its usable form, calcitriol.
And we need active vitamin D to absorb calcium from our food, right?
Absolutely. So if the kidneys aren't working properly, your body can't absorb calcium effectively, no matter how much calcium-rich food you eat or supplements you take.
Wow. So kidney failure leads to bone problems indirectly through vitamin D. And it controls blood pressure, too.
Definitely. Primarily through releasing an enzyme called renin. Renin kicks off this huge hormonal cascade, the RAAS system, which we'll definitely unpack later. It's central to blood pressure control.
Okay.
And it also produces some local hormones like prostaglandins, which help fine-tune blood flow within the kidney itself.
So you look at that list: blood cell production, activating vitamin D for bone health, regulating blood pressure via renin.
You realize the kidney is absolutely central to the function of at least three other major organ systems: circulatory, skeletal, endocrine. It's deeply interconnected.
Okay, now that we appreciate just how much it does, let's look inside. The structure. You keep mentioning the nephron and that it's non-regenerative.
Right. The structure is complex, highly vascularized as you'd expect for a filter. Each kidney has about 8 to 10 lobes, and packed within each kidney are anywhere from 800,000 to maybe 1.2 million nephrons. It varies.
And the nephron is the key functional unit.
It is. It's the microscopic, self-contained unit responsible for performing all four of those pillars we just discussed: filtering, reabsorbing, secreting, and excreting.
And the crucial point we started with.
Yeah.
After age 40, you start losing that finite number, about 10% per decade.
Yeah, that 10% per decade? It might not sound like a huge amount initially.
No, but over 30 or 40 years.
Exactly. Over decades, you can lose a really significant portion of your functional reserve, maybe 30, 40% or more by the time you're older.
And that loss becomes incredibly relevant when we start talking about kidney disease later on, doesn't it?
Absolutely. If you're operating with, say, 80% of your nephrons, you're probably fine. You won't notice. But if you suffer some kind of acute injury when you're already down to maybe 50% capacity due to age and that chronic loss,
Your chances of recovery are much worse.
significantly worse, your buffer is gone. So preserving the nephrons you have is truly a lifelong imperative.
That flows perfectly into section 2, the filtration engine and hormonal messaging. The engine itself starts at the very beginning of the nephron, right? The renal corpuscle.
Correct. The renal corpuscle is made up of two parts: the glomerulus and the surrounding Bowman's capsule.
Okay, how does this high-pressure system actually work? What's happening there?
Well, think of the renal corpuscle as the initial high-speed press. It's where the liquid component of blood is separated from the cells and large proteins. The glomerulus is basically a tiny, specialized tuft of capillaries. Blood enters it under relatively high pressure.
And Bowman's capsule.
It's like a cup or sac that completely surrounds the glomerulus, ready to catch all the fluid that leaks out under that pressure.
The actual barrier, the filter itself, is the glomerular filtration membrane. What's special about that?
It's an incredibly sophisticated filter. It has 3 layers, and it's designed to be permeable enough to let water and small solutes, waste products, ions, glucose pass through easily.
But keep the big stuff in the blood.
Precisely. It has to retain the large, valuable components. So the filtrate that successfully leaks out of the glomerulus and into Bowman's capsule contains mostly water, plus glucose, amino acids, all the waste products like urea and creatinine, and various ions: sodium, potassium, phosphate, chloride.
So pretty much everything small and dissolved gets pushed out. But the crucial diagnostic point, and we really need to stress this, is what stays behind.
Yes. Blood cells, red cells, white cells, and large plasma proteins, especially albumin, are absolutely not supposed to be filtered. They're simply too big to get through a healthy glomerular membrane.
So if a doctor finds blood cells or significant protein in your urine,
It's the #1 sign of damage to the glomerulus itself. It indicates a breakdown in that delicate filtration barrier. It tells us something's wrong right at the start of the process.
okay, once that filtrate, this watery mix of small molecules, is collected in Bowman's capsule, it starts its long journey through the rest of the nephron's plumbing, the tubules.
A surprisingly long journey, yes. If you stretched out all the tubules, it'd be miles long.
And the kidney filters gallons and gallons of this stuff every day, but we only pee out a liter or two, so it has to reclaim almost everything. Where does that massive reclaiming process begin?
It starts immediately right after Bowman's capsule in the proximal convoluted tubules, or PCT. These are located mainly in the outer part of the kidney, the renal cortex.
And the PCT is like the main sorting facility.
That's a great way to put it. It's the bulk sorting facility. This is where the major non-hormonally regulated reabsorption happens. It's just automatically pulling back the essentials.
How much are we talking? Like what percentage gets reabsorbed here?
An incredible amount. We reclaim almost 100% of the really valuable nutrients that might have slipped through the filter, specifically glucose and amino acids.
All the sugar and protein building blocks.
Yes, and along with those nutrients, a massive amount of water gets reabsorbed here too, often around 2/3, maybe 65–70% of the initial filtrate volume.
How does it pull back so much water?
It involves the active reabsorption of sodium ions. The PCT pumps sodium out of the tubule, and water just follows passively by osmosis because of the salt gradient created.
Like a high-volume factory just grabbing all the raw materials before they accidentally hit the waste stream.
Exactly. And it's not just about reabsorption. The PCT is also a key site for secretion.
Dumping things into the urine.
Right. Many organic acids and bases, including certain medications like penicillin and other antibiotics, diuretics, and various metabolic byproducts, are actively transported out of the blood surrounding the tubule and into the filtrate here for elimination. It's actively cleaning the blood in another way.
Okay, so PCT does bulk reabsorption and some active secretion. Then the filtrate moves from the cortex down deep into the kidney's inner part, the medulla, right? To the loop of Henle.
Correct. The loop of Henle dives down into the medulla and then loops back up towards the cortex. This section is absolutely dedicated to one main thing: concentrating the urine.
Which involves creating that super salty environment in the medulla you mentioned.
Yes, it's all about managing salt and water to create and maintain a hypertonic, meaning super salty interstitial environment deep in the medulla. This salty environment is the key to the kidney's ability to conserve water when needed.
It sounds complex. How does the loop achieve that?
It's a beautiful piece of biological engineering, really. It works as a countercurrent multiplier. The loop has two limbs with very different properties as the filtrate travels down the descending limb.
Going deeper into the salty medulla.
The membrane here is permeable only to water. It doesn't let salts pass easily. So as the filtrate goes down into that increasingly salty environment, water gets passively sucked out by osmosis.
Leaving the fluid inside the tubule more concentrated, more salty itself?
Exactly. By the time the filtrate reaches the bottom of the loop, it's highly concentrated. Then it makes the sharp turn and starts heading back up in the ascending limb.
And the rules change here.
Completely. The membrane of the thick ascending limb is now impermeable to water. Water cannot leave here, but it actively pumps ions, sodium, chloride, potassium out of the filtrate and into the surrounding medullary interstitium.
So it's actively pumping salt out, making the medulla salty, but keeping the water inside the tubule.
Precisely. This constant pumping of salt out of the ascending limb is what maintains that hypertonic, super salty environment in the medulla. And that salty environment, in turn, is what ensures water keeps leaving the descending limb passively. It's a self-reinforcing system.
Water leaves descending side, makes fluid salty. Salty fluid goes up ascending side, pumps salt out, makes medulla salty, which pulls more water out the descending side.
Wow.
Okay.
It's how we can produce urine much more concentrated than our blood plasma, allowing us to conserve water.
Amazing. Okay, so after the loop has done its concentration work, the filtrate moves to the distal convoluted tubule, or DCT. What happens here?
The DCT is less about massive bulk reabsorption like the PCT and more about fine-tuning. This is where hormonal control really kicks in to adjust the final composition based on the body's immediate needs.
This is where aldosterone and other hormones do their work.
Absolutely. In the DCT, sodium, water, and bicarbonate are reabsorbed, but under much tighter regulated control. Specifically, the hormone aldosterone, which we'll discuss more with RAAS, acts here to increase the reabsorption of sodium, and water follows.
Okay.
Also, parathyroid hormone, PTH, acts on the DCT to increase the reabsorption of calcium, helping to keep our blood calcium levels stable.
And secretion happens here too.
Yes, this is a key site for secreting excess hydrogen ions to manage acid-base balance and excess potassium into the tubule for elimination, fine-tuning based on blood levels.
And finally, after the DCT, we reach the end of the line, the collecting duct.
The collecting duct is the final checkpoint. Several DCTs drain into one collecting duct, which passes down through that salty medulla one last time on its way to the renal pelvis.
And this is where the final decision about water retention is made.
Exactly. The permeability of the collecting duct to water is controlled by antidiuretic hormone, ADH, also known as vasopressin.
ADH, anti-P hormone.
Essentially, yes. If the body needs to conserve water, like if you're dehydrated, the pituitary gland releases ADH. ADH makes the collecting duct walls highly permeable to water. As the filtrate passes down through the super salty medulla, tons of water gets pulled out one last time, making the final urine very concentrated.
And if you're well hydrated, less ADH is released.
Correct. Less ADH means the collecting duct stays relatively impermeable to water. Water stays in the tubule and you produce more dilute urine. Urea is also reabsorbed from the collecting duct into the medulla here, helping to maintain that osmotic gradient.
It's an incredibly intricate system of plumbing and chemistry.
It really is.
Now that we understand the plumbing, we absolutely have to talk about the master control system you mentioned earlier,
Yeah.
the RAAS, the renin-angiotensin-aldosterone system, probably the most famous hormonal feedback loop for blood pressure.
It is. The RAAS is the body's ultimate emergency response mechanism for low blood pressure or low blood volume. And what's fascinating is how it starts right in the kidney.
How does it get triggered?
Specialized cells right near the glomerulus, called the juxtaglomerular cells, act as sensors. They constantly monitor blood pressure in the afferent arteriole, the vessel entering the glomerulus, and sodium concentration in the filtrate passing through the DCT, if they detect a significant drop in blood pressure or low sodium.
Meaning the kidney itself isn't getting enough blood flow, or the body might be dehydrated?
Exactly. They perceive a crisis, and their response is to release an enzyme called renin directly into the bloodstream.
So renin is the initial alarm signal.
It's the first domino. Renin circulates in the blood until it bumps into a protein called angiotensinogen, which is always floating around, produced constantly by the liver.
Okay.
Renin acts like molecular scissors. It cleaves angiotensinogen, cutting off a piece to create a smaller peptide called angiotensin the shit.
Is angiotensin I active?
Not very. It's mostly an inactive precursor, just waiting for the next step. The massive amplification happens next.
Where does that happen?
As angiotensin I circulates through the body, it encounters another enzyme called ACE, angiotensin converting enzyme. ACE is found in many places, but is particularly abundant on the surface of endothelial cells lining the blood vessels in the lungs and also in the kidneys.
And ACE is the key converter.
It's the amplification switch. ACE rapidly converts the relatively weak angiotensin I into an incredibly potent hormone called angiotensin II. This is the real workhorse of the system.
Angiotensin II. Okay, what does it do that's so potent?
It has two major immediate effects, both designed to fix the low blood pressure crisis. First, it is one of the most powerful vasoconstrictors the body makes.
Meaning it squeezes blood vessels.
Yes, it causes the smooth muscle and arterioles all over the body to clamp down hard. This dramatically increases systemic vascular resistance, basically. It tightens the pipes, which drives blood pressure up almost instantly.
Wow, okay. Direct pressure increase with a second effect.
Its second major action is to demand fluid retention. It wants to increase the volume in those pipes.
How does it do that?
It acts on multiple targets. First, it stimulates the adrenal cortex, which sits on top of the kidneys, to release aldosterone.
And aldosterone acts on the DCT.
To increase sodium and water reabsorption, like we discussed, hold on to salt and water. Second, angiotensin II also signals the pituitary gland in the brain to release ADH vasopressin.
Which makes the collecting ducts reabsorb more water.
Correct. So angiotensin II simultaneously constricts the blood vessels and tells the kidneys, via aldosterone and ADH, to hold on to every possible drop of salt and water. The combined effect is a rapid and powerful increase in blood pressure and volume.
That makes the clinical connection crystal clear.
Yeah.
If angiotensin II is such a powerful driver of high blood pressure.
Then blocking its production or its action is a prime target for treatment.
Like ACE inhibitors.
Exactly. Medications known as ACE inhibitors block that conversion step from angiotensin I to angiotensin II. By preventing the formation of the super potent angiotensin II, they prevent the vasoconstriction and reduce the signaling for salt and water retention. This lowers blood pressure.
Makes perfect sense. It's a cornerstone of treating hypertension and even heart failure.
Absolutely. Understanding RAAS is fundamental to cardiovascular medicine.
Okay, we know how the engine works, how it's controlled. Let's move to section 3. Checking the system. How do we actually test renal function?
The most important blood test, really the workhorse, is measuring creatinine.
We mentioned creatinine earlier as a waste product. Why is it so useful?
Creatinine is a byproduct of normal creatine metabolism in your muscles. It's produced at a relatively constant rate, day in, day out, depending mostly on your muscle mass.
Okay.
The crucial point is that creatinine is freely filtered by the glomeruli, but once it's in the filtrate, it's essentially not reabsorbed back into the blood by the tubules. Maybe a tiny bit is secreted, but for practical purposes, it's filtered and then excreted.
So if the kidneys are filtering efficiently, all the creatinine produced should end up in the urine, and blood levels should stay low and stable.
Precisely. If the kidney's filtering ability declines, they can't clear the creatinine effectively, so it starts to back up in the blood. A high blood creatinine level is therefore a direct indicator of poor kidney function, specifically poor filtration.
And this is related to GFR.
Yes. The GFR, or glomerular filtration rate, is the theoretical measure of how much blood plasma is completely cleared of a substance, like creatinine, by the kidneys per minute. It's the best overall measure of kidney function.
How is it measured? Do you still need the 24-hour urine collection?
Historically, yes, that was the gold standard for creatinine clearance. But it's cumbersome. Nowadays, we almost always use an estimated GFR, eGFR. This is calculated using a formula that takes into account your blood creatinine level, age, sex, and sometimes race. It's reported on most standard metabolic panels now.
So the eGFR gives us a number like ml per minute, representing filtering capacity.
Correct. A normal GFR is typically above 90 millimin, often over 100. As kidney disease progresses, the GFR falls.
We often see creatinine reported alongside BUN, or blood urea nitrogen. How does BUN compare?
Urea, as we said, is the end product of protein metabolism formed in the liver. Like creatinine, it's filtered by the kidneys, and its levels also rise when kidney function declines.
Well,
But BUN is much less specific and less sensitive than creatinine as a sole marker of kidney function. Its levels can fluctuate quite a bit based on factors other than kidney filtration.
such as.
High protein intake is a big one. If you eat a lot of protein, your liver makes more urea, and your BUN will rise even if your kidneys are perfectly healthy.
Okay, what else?
Dehydration. If you're dehydrated, your blood becomes more concentrated and BUN levels go up. Also, significant bleeding into the gastrointestinal tract can increase BUN because the digested blood protein gets metabolized into urea. Certain medications like steroids can also raise it.
So BUN can be high for reasons unrelated to kidney failure.
Exactly. That makes creatinine, and especially the eGFR derived from it, the more reliable marker for tracking chronic kidney damage over time.
And you mentioned something earlier about how much function needs to be lost before BUN gets significantly elevated purely due to kidney failure.
Yeah, our sources highlight this remarkable point. For BUN to be significantly elevated solely because the kidneys aren't clearing it, you typically need to have lost about 2/3, maybe 60–70% of your overall kidney function.
Wow, 2/3 lost before that marker really jumps. That speaks volumes about the kidney's reserve capacity.
It truly does. You have a massive built-in redundancy with all those nephrons. You can lose quite a lot before routine tests like BUN start looking seriously abnormal.
It's like having a huge backup generator that you don't even realize is running until the main power grid is mostly down.
That's a good analogy. Finally, beyond blood tests, we use urinalysis, the simple urine dipstick and microscopic exam.
What key things do we look for there?
We look at specific gravity, which measures the urine's concentration. Healthy kidneys can produce very concentrated or very dilute urine depending on hydration. If the specific gravity is consistently low, like close to water, it suggests the tubules are damaged and losing their ability to concentrate urine.
And obviously looking for things that shouldn't be there.
Right. We look for infection markers like white blood cells and nitrates. We look for protein, proteinuria, and blood hematuria, which, as we said, point towards glomerular damage. Looking at the urine sediment under a microscope can also reveal casts little molds of the tubules made of cells or protein, which give clues about where the damage might be.
Okay, that gives us a good picture of how we monitor the system. Let's transition now into section 4. When things go wrong, major renal disorders. We can start with structural problems, specifically cystic diseases of the kidney.
Right. Cystic diseases involve the formation of fluid-filled sacs, or cysts, within the kidney tissue. The key distinction is often between the inherited forms and acquired cysts.
What's the most common inherited type?
That would be autosomal dominant polycystic kidney disease, or ADPKD. Dominant means you only need one copy of the faulty gene, usually inherited from one parent.
What happens in ADPKD?
In ADPKD, numerous large, fluid-filled cysts develop throughout both kidneys. They often look like clusters of grapes growing out from the kidney surface, the cortex. They gradually enlarge over decades.
And how does that manifest clinically? What are the symptoms?
Because it's dominant and the cysts grow slowly, it often doesn't cause significant problems until middle age, typically presenting between ages 30 and 50. As the cysts enlarge, they compress and destroy the surrounding healthy kidney tissue.
Leading to.
Common manifestations include chronic flank pain, blood in the urine, hematuria from cysts rupturing, recurrent urinary tract infections, UTIs, and very commonly high blood pressure, hypertension, often difficult to control.
And eventually, kidney failure.
Yes. ADPKD is a leading cause of end-stage renal disease, ESRD. Over time, the cyst growth obliterates normal function, and many patients eventually require dialysis or a kidney transplant, usually later in life.
Then there's a rarer, more severe form.
Yes, autosomal recessive polycystic kidney disease, ARPKD. Recessive means you need two copies of the faulty gene, one from each parent.
How does ARPKD differ?
It's much rarer and typically presents very early, often in infancy or even detected prenatally. The cysts in ARPKD are different too. They are smaller, more elongated, and primarily affect the collecting ducts deep within the kidney. It's often associated with liver fibrosis as well.
And the prognosis?
Unfortunately, ARPKD has a very high morbidity and mortality rate, especially in newborns. Many affected infants develop severe respiratory problems due to underdeveloped lungs, pulmonary hypoplasia, related to low amniotic fluid during gestation, caused by poor fetal kidney function, and rapid progression to renal failure is common. Survival rates have improved, but it remains a very serious condition.
You also mentioned nephronophthisis briefly in the outline.
Right. Nephronophthisis, NPHP, is another group of inherited cystic kidney diseases, but it's characterized by cysts mainly at the corticomedullary junction, along with tubular atrophy and interstitial fibrosis. It's a leading genetic cause of ESRD in children and young adults.
So childhood onset, progressing to failure relatively early.
Yes, typically leading to end-stage renal disease before the age of 30, often in the teenage years. The kidneys tend to be small or normal-sized, unlike the massively enlarged kidneys in ADPKD.
And simple cysts.
Oh, simple or acquired renal cysts are incredibly common, especially as people age. They're usually found incidentally on imaging, are typically benign, don't cause symptoms, and rarely affect kidney function. We usually just monitor them.
But for the significant cystic diseases like ADPKD, the common themes seem to be pain, hematuria, infections, and hypertension due to that ongoing structural damage.
That's the typical picture, yes. The physical compression from the cysts causes pain and damages tissue, leading to bleeding. The altered architecture and potentially impaired urine flow can predispose to UTIs. And the kidney's response to injury often involves activating pathways like RAAS, contributing to hypertension.
Okay, moving from cysts to something acutely painful. Obstructive disorders, primarily kidney stones or renal calculi. What's the basic process? How does a stone even form?
It's fundamentally a process of supersaturation chemistry happening within the urine. It generally follows 3 steps.
Simple one.
Supersaturation. This means the concentration of certain minerals in the urine, things like calcium, oxalate, phosphate, uric acid, becomes higher than the level at which they can normally stay dissolved. The urine is holding more solute than it should be able to.
Okay, the urine is overloaded with stone-forming stuff. Step 2.
Precipitation or nucleation. When supersaturation occurs, especially if conditions are right, like a change in urine pH, the dissolved mineral salts start to change phase. They come out of solution and form tiny, solid crystals, like sugar crystallizing out of oversaturated syrup.
And these tiny crystals are the seeds.
Exactly. Step 3 is growth and aggregation. These initial microscopic crystals can then grow larger by adding more mineral layers, or they can clump together aggregate with other crystals. If this process continues unchecked, they eventually form a macroscopic stone.
And if that stone gets big enough to block urine flow?
That's when you get symptoms. If it stays small, it might pass unnoticed. If it grows large or gets lodged in a narrow part of the urinary tract, like the ureter, it causes obstruction and intense pain.
The type of stone tells us something about why it formed, right?
Yeah.
What are the main kinds?
Yes, analyzing the stone's composition is crucial for prevention. By far the most common, making up maybe 70–80% of stones, are calcium-based stones, usually calcium oxalate, sometimes calcium phosphate.
What causes those?
Often linked to high levels of calcium in the urine, hypercalciuria, which can have various causes, including absorbing too much calcium from the diet, kidney problems handling calcium, or sometimes conditions like hyperparathyroidism or excess vitamin D. High oxalate levels in urine from diet or metabolism are also key for oxalate stones.
Okay, calcium stones are most common. What else?
We see struvite stones, also called magnesium ammonium phosphate stones. These are almost always associated with chronic urinary tract infections caused by specific bacteria, like Proteus, that produce an enzyme called urease. Urease breaks down urea, makes the urine alkaline, and promotes struvite precipitation. These can grow very large, sometimes filling the whole renal pelvis, forming staghorn calculi.
Infection stones. What about gout-related stones?
Those are uric acid stones. They form when there's too much uric acid in the urine, often seen in people with gout, those eating very high purine diets like lots of red meat and organ meats, or certain metabolic conditions. These stones tend to form in acidic urine.
And lastly,
Less common are cystine stones. These are caused by a rare inherited genetic disorder where the kidneys don't properly reabsorb the amino acid cysteine, leading to high levels in the urine and stone formation.
so knowing the type helps guide prevention like lowering calcium, treating infections, reducing purines. Are there natural things in urine that prevent stones?
Yes, absolutely. Urine normally contains several substances that act as inhibitors of crystal formation and growth. The two most important are probably citrate and magnesium.
How does citrate work?
Citrate binds with calcium in the urine, forming a soluble complex. This means there's less free calcium available to bind with oxalate or phosphate to form crystals. Low urinary citrate, hypocitraturia, is a major risk factor for calcium stones, which is why treatments often involve increasing citrate levels, like taking potassium citrate supplements or drinking lemonade.
And magnesium.
Magnesium also inhibits calcium oxalate crystallization, though perhaps less potently than citrate. Maintaining adequate magnesium levels is beneficial.
When a stone does form and causes an obstruction, you mentioned it leads to intense pain. What are the two main damaging effects of that blockage on the kidney itself?
The obstruction is dangerous for two key reasons. First, and most immediately, it causes stasis of urine. Urine flow stops or slows dramatically proximal to above the blockage.
And stagnant urine is bad news.
Very bad. It becomes an ideal breeding ground for bacteria, significantly increasing the risk of developing a serious kidney infection, pyelonephritis, behind the stone. Stasis also promotes further stone growth.
Okay, infection risk. What's the second damaging effect?
The second is the physical consequence of the back pressure. The blockage causes progressive dilation of the ureter, renal pelvis, and cowlices the entire collecting system above the stone. This condition is called hydronephrosis.
And that pressure buildup hurts the kidney tissue.
Yes, this sustained high pressure within the kidney compresses the delicate renal tissue, particularly the tubules and blood vessels in the medulla. Over time, this pressure causes atrophy, shrinking, and death of renal cells and can lead to irreversible loss of kidney function if the obstruction isn't relieved relatively quickly.
So the pain is bad, but the real dangers are infection and pressure damage.
Correct. That's why relieving urinary obstruction is often an urgent priority. Clinical signs are usually that sudden, severe flank pain, renal colic, often radiating to the groin, sometimes nausea, vomiting, blood in the urine, hematuria, and urinary urgency or frequency.
Okay, let's shift from stones blocking the flow to infections within the system. Infectious and interstitial disorders, starting with the very common urinary tract infection, or UTI.
UTIs are incredibly common, especially in women. We generally categorize them by location. Lower UTIs involve the bladder, cystitis, and the urethritis. Upper UTIs are more serious and involve the ureters and the kidney itself, pyelonephritis.
How do most UTIs start?
Overwhelmingly, the vast majority of UTIs are caused by bacteria ascending from the perineal area through the urethra and up into the bladder. The number one culprit by far is Escherichia coli, E. coli, a bacterium that normally lives in the gut.
And this ties back to obstruction again, doesn't it?
Absolutely. Anything that causes urinary stasis, incomplete bladder emptying due to obstruction, like an enlarged prostate or a stone, nerve problems affecting bladder control, or even just infrequent voiding significantly increases the risk of UTI. The stagnant urine allows any bacteria that reach the bladder to multiply much more easily before being flushed out.
It creates a welcoming environment for them.
Exactly. It's
Yeah.
a vicious cycle. Obstruction leads to stasis, stasis promotes infection, and sometimes the infection itself, like with struvite stones, can contribute to further obstruction.
When that infection ascends from the bladder up the ureters to the renal pelvis and the kidney tissue itself, that's pyelonephritis.
Correct. Pyelonephritis is a kidney infection. We distinguish between acute and chronic forms.
What characterizes acute pyelonephritis?
Acute pyelonephritis typically presents abruptly with signs of a serious systemic infection. High fever, chills, shaking, nausea, vomiting, and flank pain. Costovertebral angle tenderness. It's usually caused by bacteria, often gram-negative rods like E. coli, ascending from a lower UTI. It often occurs in the presence of some underlying factor like reflux, urine flowing backward up the ureter, or obstruction.
And chronic pyelonephritis.
Chronic pyelonephritis is a different beast. It's usually a slower, more insidious process resulting from recurrent or persistent kidney infections, often superimposed on underlying structural abnormalities, vesicuratorial reflux, or chronic obstruction.
What's the long-term damage?
Chronic inflammation leads to progressive scarring and deformation of the renal calyces and pelvis. This scarring destroys kidney tissue over time, leading to significant long-term complications like persistent hypertension, high blood pressure, impaired ability to concentrate urine, and eventually chronic kidney disease and potential renal failure. It's a much more gradual but ultimately destructive process.
Okay, finally, in this section on disorders, let's turn to problems with the filter itself. Glomerular disorders, often grouped under the term glomerulonephritis.
Glomerulonephritis basically means inflammation of the glomeruli, those tiny filtering units we talked about. It's not a single disease, but rather a collection of conditions that damage the glomeruli.
What typically causes this inflammation?
Many cases are triggered by the immune system. Often, it occurs following an infection elsewhere in the body, classically a streptococcal infection, like strep throat or impetigo. What happens is the immune system creates antibodies and immune complexes to fight the infection, but these complexes then circulate and get trapped in the delicate structures of the glomeruli.
And the trapped complexes trigger inflammation.
Exactly. They activate the complement system and attract inflammatory cells, which release damaging chemicals and enzymes, leading to injury of the glomerular filtration barrier. Other causes can include autoimmune diseases like lupus or primary kidney diseases affecting only the glomeruli.
When that filter gets inflamed and damaged, what are the classic signs we see?
Because the filtration barrier is compromised, the hallmark signs show up immediately in the urine and blood tests. You typically see hematuria blood in the urine. Under the microscope, you might see red blood cell casks, which are clumps of red cells shaped like the tubules, strongly indicating the bleeding originated within the nephron, likely the glomerulus.
And protein.
Yes, proteinuria protein spilling into the urine because the damaged filter lets larger molecules like albumin leak through. The inflammation also reduces the overall filtering efficiency, so you often see a decreased GFR, glomerular filtration rate, and sometimes oliguria, which is low urine output because less filtrate is being formed. Fluid retention and hypertension can also occur.
We often hear about two main clinical pictures or syndromes associated with glomerulonephritis, nephritic versus nephrotic syndrome. Can you contrast those?
Right. While there can be overlap, they represent different patterns of glomerular injury and resulting symptoms. Acute nephritic syndrome is characterized primarily by that inflammation, so the dominant features are hematuria, often macroscopic, visible blood, red cell casts, some degree of proteinuria, usually mild to moderate, decreased GFR, oliguria, fluid retention leading to edema, and hypertension. Think inflammation and reduced filtering.
And nephrotic syndrome.
Nephrotic syndrome is defined by a much more severe damage to the glomerular filtration barrier, leading to a massive increase in its permeability, specifically to proteins. The defining feature here is massive proteinuria, losing huge amounts of protein, more than 3.5 grams per day in the urine.
Losing that much protein must have major consequences.
Absolutely. This leads to the other key features of nephrotic syndrome. The massive loss of albumin, the main protein in blood, causes hypoalbuminemia, low albumin levels in the blood.
And low albumin disrupts fluid balance.
Critically, albumin is responsible for maintaining oncotic pressure, which holds fluid inside blood vessels. When albumin levels plummet, fluid leaks out into the interstitial tissues, causing generalized, often severe edema, swelling, often seen first around the eyes and ankles, but can become body-wide anasarca.
Does the body try to compensate?
Yes, but it actually makes things worse. The low albumin and fluid shift out of the vessels can make the body think blood volume is low. This triggers the RAAS system.
Renin, angiotensin, aldosterone.
Leading to salt and water retention by the kidneys. But because the albumin is still low, this retained fluid just leaks out too, exacerbating the edema. It's a vicious cycle.
What else is characteristic of nephrotic syndrome?
You also typically see lipiduria, fats in the urine, and hyperlipidemia, high levels of cholesterol and triglycerides in the blood. This is thought to be partly due to the liver trying to compensate for the protein loss by ramping up production of lipoproteins. So massive proteinuria, low albumin, severe edema, and high lipids are the hallmarks of nephrotic syndrome. It signifies very leaky glomeruli.
That really highlights how damage to that tiny filter can cause system-wide chaos. This brings us logically to the next stage. Section 5. Acute versus chronic renal failure and treatment. First, how do we define the spectrum of failure?
It's a continuum of declining function. We might talk about renal insufficiency when kidney function, measured by GFR, drops significantly, maybe down to around 25–30% of normal. The kidneys are damaged but can still mostly cope, though waste products might start to accumulate.
Then renal failure.
Renal failure implies a more severe loss of function, where the kidneys can no longer maintain internal stability without intervention. And finally, end-stage renal failure, ESRF, or end-stage kidney disease, ESKD, is typically defined as having less than 10–15% of normal kidney function remaining. At this point, renal replacement therapy, dialysis, or transplant is required to sustain life.
Let's start with acute kidney injury, AKI. This implies a sudden decline, right? Potentially reversible.
Yes, AKI is characterized by an abrupt loss of kidney function, usually developing over hours to days. The key is that if the underlying cause is identified and treated promptly, kidney function can often recover, sometimes fully.
How do we categorize the causes of AKI?
We usually think about them based on where the problem originates relative to the kidney: prerenal, intrarenal, or postrenal.
Okay, pre-renal AKI.
Pre-rening before the kidney. These are causes that severely reduce blood flow to the kidneys. The kidneys themselves might be perfectly healthy initially, but they aren't getting enough blood supply to function.
What kind of situations cause that?
Anything leading to significantly low blood pressure or low circulating volume. Examples include severe hemorrhage, profound dehydration, major burns, anaphylactic shock, severe sepsis where blood vessels dilate massively, or advanced heart failure where the heart can't pump enough blood forward. The common theme is inadequate renal perfusion.
Okay, so fix the blood flow and the kidneys might recover. What about intrarenal AKI?
Intra, meaning inside the kidney. This involves direct damage to the kidney structures themselves, the glomeruli, the tubules, the interstitium, or the blood vessels within the kidney.
What causes direct damage?
Lots of things. Prolonged severe ischemia, lack of oxygen, for example. If a prerenal state goes untreated for too long, the kidney cells start to die. Direct toxicity from certain medications, like some antibiotics, especially aminoglycosides, NSAIDs, chemotherapy drugs, contrast dye used in imaging, infections within the kidney, like severe pyelonephritis, rhabdomyolysis, muscle breakdown releasing toxic substances, glomerulonephritis, as we discussed. The most common type of intrarenal AKI is acute tubular necrosis, ATN, where the tubule cells themselves are injured, often by ischemia or toxins.
And finally, postrenal AKI.
Post meaning after the kidney. This is caused by an obstruction to urine flow leaving the kidneys. Urine backs up, increasing pressure within the tubules and shutting down filtration.
Like kidney stones.
Exactly. Bilateral kidney stones, or a stone in a single functioning kidney. Severe bladder outlet obstruction, like from a massively enlarged prostate or bladder cancer. Or blockage of the ureters by tumors or fibrosis. The obstruction has to affect outflow from both kidneys, or a solitary kidney, to cause AKI.
AKI often progresses through distinct phases, doesn't it?
Yes, classically there are 4 phases, although not every patient goes through all of them clearly. First is the onset or initiation phase. This is the period from the initial insult, like hemorrhage or toxin exposure, until the signs of kidney injury begin.
Then the critical phase.
Often the oliguric phase. Oliguria means low urine output, typically defined as less than 400 milliliters in 24 hours. Some definitions use 0.5 milliliters UHHR. This phase can last anywhere from a few days to several weeks.
And this is where the problems really mount.
Oh. Yes. Because the kidneys aren't filtering effectively, waste products, BUN, creatinine, build up rapidly in the blood, azotemia. Fluid retention becomes severe, leading to edema, hypertension, and potentially pulmonary edema, fluid in the lungs. Electrolyte imbalances are critical, especially hyperkalemia, high potassium, which is life-threatening because it can cause fatal cardiac arrhythmias. Metabolic acidosis also develops. This is often the most dangerous phase.
If the patient gets through that, what's next?
Hopefully the diuretic phase. This signals that the kidney tubules are starting to recover and regenerate, and GFR begins to increase. Urine output starts to rise dramatically, sometimes reaching several liters per day, polyuria.
Which sounds good, but has its own risks.
It does. While the kidneys are now filtering fluid, the recovering tubules aren't yet fully capable of reabsorbing electrolytes and concentrating the urine properly. So patients can lose large amounts of sodium, potassium, and water, leading to dehydration and electrolyte depletion if fluids aren't managed carefully. We have to monitor closely for hypokalemia and hyponatremia during this phase.
And the final phase.
The recovery phase. This is the period where tubular function gradually improves, GFR continues to rise, and BUN and creatinine levels return towards normal. This phase can be quite long, potentially lasting from 3 months up to a year or even longer for full recovery. Unfortunately, some patients, especially those with severe AKI or pre-existing kidney issues, may not fully recover and can progress to having chronic kidney disease.
Which brings us to chronic kidney disease, CKD.
Mm.
This isn't sudden, it's a progressive, irreversible decline over months or years.
Exactly. CKD is defined by evidence of kidney damage, like persistent proteinuria or abnormal structure, or a GFR less than 60 millimolin lasting for 3 months or longer. It's a gradual loss of nephrons.
What are the main drivers of CKD, especially in developed countries?
The two dominant causes, accounting for the vast majority of cases, are systemic diseases that damage the kidney's vasculature over time. Number one is diabetes mellitus, both type 1 and type 2. High blood sugar levels damage the tiny blood vessels in the glomeruli, diabetic nephropathy, impairing filtration.
And number two,
Chronic, poorly controlled hypertension, high blood pressure. Sustained high pressure damages the small arteries and arterioles within the kidney, leading to nephrosclerosis, hardening of the kidney vessels, and glomerular damage. Essentially, diabetes causes damage through metabolic factors and high sugar, while hypertension causes damage through excessive pressure.
what else contributes?
Obesity is a major risk factor, often linked with both diabetes and hypertension. Other factors include cardiovascular disease, glomerulonephritis that becomes chronic, polycystic kidney disease, recurrent kidney infections, and long-term obstruction. Age itself is a risk factor due to that natural nephron loss.
Now, this is where the deep dive gets really systemic. CKD isn't just a kidney problem, it's a failure of the body's master regulator. The consequences ripple through every other system. Let's unpack those systemic impacts.
They are profound and widespread as GFR declines. Let's start with fluid and electrolyte balance. As kidneys fail, they lose the ability to regulate sodium and water excretion effectively.
Leading to fluid overload.
Yes, sodium and water retention is common, contributing significantly to hypertension, worsening heart failure, volume overload, and causing peripheral and pulmonary edema.
And potassium.
Critically important. The kidneys are the main route for excreting dietary potassium. As GFR falls, especially below 20-30 LLM, the ability to excrete potassium diminishes, leading to hyperkalemia. As we said with AKI, this is extremely dangerous due to the risk of fatal cardiac arrhythmias. It's a major concern in advanced CKD.
Okay, fluid overload and high potassium. What about the buildup of waste products?
This is called uremia, the complex of symptoms resulting from the accumulation of urea and other nitrogenous waste products that are normally cleared by the kidneys. Uremia affects virtually every organ system.
How does it affect the brain?
In the central nervous system, uremic toxins can cross the blood-brain barrier, causing uremic encephalopathy. This manifests as a spectrum of neurological symptoms: lethargy, fatigue, difficulty concentrating, confusion, progressing to delirium, seizures, asterixis, a characteristic flapping tremor of the hands, and eventually coma if untreated.
What about the gut?
Gastrointestinal issues are very common. Nausea, vomiting, loss of appetite, anorexia, a metallic taste in the mouth, and uremic fetor, a urine-like odor on the breath, can occur. Uremia also impairs platelet function, leading to increased risk of bleeding and bruising.
We also mentioned hematologic problems earlier, specifically anemia.
Yes, because the failing kidneys stop producing enough erythropoietin, EPO, patients develop anemia, normocytic, normochromic anemia. This contributes significantly to the fatigue, weakness, and reduced exercise tolerance seen in CKD. Synthetic EPO is a standard treatment.
And acid-base balance.
Failing kidneys can't excrete the daily load of metabolic acids produced by the body, nor can they regenerate bicarbonate effectively. This leads to chronic metabolic acidosis, which can worsen bone disease and protein breakdown.
Okay, let's focus now on that really intricate cascade you mentioned, the impact of CKD on bone and mineral metabolism. This is often called CKD-MBD, mineral and bone disorder.
It's a complex interplay, absolutely central to CKD management. It really starts with two key problems caused by the failing kidneys. First, as we established, the damaged kidney loses its ability to perform that final activation step for vitamin D.
So you get deficient in active vitamin D, calcitriol.
Right. And without sufficient active vitamin D, the gut cannot absorb dietary calcium effectively. This leads to a tendency towards low serum calcium or hypocalcemia.
Okay, low active D leads to low calcium absorption. What's the second key problem?
The failing kidneys also lose their ability to excrete phosphate efficiently. Phosphate comes from our diet, especially protein-rich foods.
Hmm.
As GFR falls, phosphate starts to accumulate in the blood, leading to hyperphosphatemia.
High phosphate, and there's an inverse relationship between phosphate and calcium, isn't there?
Yes, high phosphate levels in the blood tend to bind with calcium, further lowering the levels of free ionized calcium. So hyperphosphatemia makes the hypocalcemia worse. Additionally, high phosphate itself directly stimulates the parathyroid glands.
So we have low active vitamin D, low serum calcium, and high serum phosphate. The body cannot tolerate low calcium levels for long because calcium is essential for nerve function, muscle contraction, blood clotting.
Exactly. The body's primary defense against low calcium is the parathyroid gland. Located in the neck, these glands sense the low calcium and high phosphate and low active vitamin D and respond by dramatically increasing their production and release of parathyroid hormone, PTH. This condition is called secondary hyperparathyroidism.
And PTH's main job is to raise blood calcium levels no matter the cost.
That's its mission. PTH tries to raise calcium in several ways, but in CKD, the most relevant and ultimately damaging way is by acting on the skeleton. PTH stimulates osteoclasts, the cells that break down bone, to release calcium and phosphate from the bones into the bloodstream.
So the body starts literally dissolving its own bones to maintain blood calcium levels.
Precisely. It's sacrificing long-term skeletal integrity for short-term maintenance of serum calcium. This leads to renal osteodystrophy, a complex spectrum of bone diseases, including high-turnover bone disease, due to excess PTH causing rapid breakdown and rebuilding, or low turnover bone disease, adynamic bone disease. Bones become weak, prone to fracture, and persons can experience bone pain.
It's an incredible example of interconnectedness and compensatory mechanisms going awry.
It truly is. Managing CKD-MBD requires a multi-pronged approach. Dietary phosphate restriction, phosphate binders, medications taken with meals to block phosphate absorption, supplements of active vitamin D or its analogs, and sometimes drugs to control the overactive parathyroid glands, calcimimetics.
Okay, let's quickly walk through the stages of CKD, which are primarily based on GFR.
Right, the staging helps guide management. Stage ICKD means kidney damage is present for G proteinuria, but GFR is still normal or high, right 90 milliman, usually asymptomatic. Stage 2 is mild CKD with GFR between 60-89 milliman, again often asymptomatic, but hypertension may start to develop or worsen. Management focuses on controlling underlying causes like diabetes and blood pressure.
And stage 3.
Stage 3 is moderate CKD, split into ITHEA, GFR 45 to 59, and IIB, GFR 30-44. This is often when the complications we've discussed start to become more apparent in lab tests, like early signs of anemia or mineral imbalances. Symptoms like fatigue might begin.
Stage 4 is severe.
Yes, stage 4 CKD is severe with GFR between 15 and 29 millimolum. Now, the systemic complications are usually quite evident. Significant anemia, metabolic acidosis, hyperkalemia becomes a risk, bone disease progresses, uremic symptoms like fatigue, nausea, and poor appetite often appear. Preparation for renal replacement therapy usually begins here.
And stage V is kidney failure.
Stage V CKD is kidney failure, or ESRD, defined as GFR less than 15 ll-in, or the need for dialysis. At this point, kidney function is insufficient to sustain life, and renal replacement therapy is necessary. All the systemic complications are typically severe.
What are the main options for renal replacement therapy?
There are essentially three main categories. First is dialysis, which artificially filters the blood. This includes hemodialysis, where blood is pumped out of the body through an artificial kidney machine, dialyzer, and then returned to the body. This is typically done 3 times a week for several hours at a dialysis center or sometimes at home.
And the other type of dialysis?
Peritoneal dialysis, PD. This uses the patient's own peritoneal membrane, the lining of the abdominal cavity, as the filter. Dialysis fluid, dialysate, is instilled into the abdomen through a catheter, allowed to dwell for several hours, drawing waste products and excess fluid across the membrane, and then drained out. This is usually done daily at home, either manually several times a day or overnight using a machine cycler.
And sometimes in the ICU.
Yes, for critically ill patients with AKI or unstable CKD, continuous renal replacement therapy, CRRP, is often used in the intensive care unit, ICU. This is a much slower, gentler, continuous form of dialysis running 247, better tolerated by patients with unstable blood pressure.
And the definitive treatment.
The ideal treatment, offering the best quality of life and long-term survival, is a renal transplant receiving a healthy kidney from a living or deceased donor. However, it requires major surgery, lifelong immunosuppressant medications to prevent rejection, and isn't suitable for everyone.
Okay, we've covered structure, function, testing, diseases, and failure. Let's wrap up with Section 6. A quick look at pharmacological management of some common urinary issues, not kidney failure itself, but more symptomatic bladder problems.
Right, three key categories here. First, urinary analgesics. The classic example is phenazopyridine HCl, often known by brand names like Pyridium or Azo.
What does it do?
It provides symptomatic relief from pain, burning, urgency, and frequency associated with urinary tract irritation, often from infection, UTI, or procedures. It acts locally as a topical analgesic on the mucosa lining the urinary tract. It doesn't treat the underlying infection, just the symptoms.
Now, phenazopyridine has one very famous, very visible side effect.
Yes, it's unforgettable. It causes the urine to turn a bright, vivid, reddish-orange color. It can also discolor tears and stain contact lenses or clothing. It's harmless, but patients absolutely need to be warned about it so they don't panic.
Good warning.
Mm.
Okay, second category. Drugs to help you urinate urinary stimulants, like bethanyl.
Yes, bethanyl is a cholinergic agonist. Cholinergic refers to acetylcholine, the neurotransmitter of the parasympathetic nervous system, the rest and digest system.
How does that help urination?
The parasympathetic system stimulates bladder contraction via the detrusor muscle and relaxation of the bladder outlet. Bethanyl mimics acetylcholine, increasing the tone and contractions of the bladder muscle, helping to initiate and promote urination. It's primarily used for non-obstructive urinary retention, like sometimes seen after surgery or in certain neurological conditions.
Since it ramps up rest and digest functions everywhere, there must be situations where you wouldn't use it.
Absolutely. Because it stimulates overall parasympathetic activity, it can increase stomach acid secretion and gastrointestinal motility. Therefore, it's contraindicated in patients with active peptic ulcers, bowel obstruction, or recent bowel surgery. It can also cause bronchoconstriction, so caution is needed in asthma.
Makes sense. Finally, the opposite. Drugs to stop unwanted urination or spasms, urinary antispasmodics, often also called anticholinergics, like oxybutynin.
Exactly. Oxybutynin is a prime example. These drugs are used mainly to treat symptoms of overactive bladder, OAB, urinary urgency, frequency, and urge incontinence, leakage.
How do they work?
They work primarily by relaxing the smooth muscle of the bladder, the detrusor muscle. Oxybutynin has both direct antispasmodic effects on the muscle and anticholinergic properties. Anticholinergics means it blocks the action of acetylcholine at muscarinic receptors on the bladder muscle.
Blocking the parasympathetic signal tells the bladder to contract.
Precisely. By blocking that signal, it reduces involuntary bladder contractions or spasms, increases the bladder's storage capacity, and delays the initial urge to void.
And because it's stopping the bladder from contracting effectively, you need to be careful if there's already a blockage.
Definitely. If a patient has significant bladder outlet obstruction, like from severe BPH, giving an anticholinergic drug could potentially worsen urinary retention by making it even harder for the bladder to overcome the blockage. It could tip them into complete retention, which is an emergency. So caution is needed in patients with known or suspected obstruction.
This has been an incredible deep dive. It really confirms the kidney is so much more than just a simple filter.
Absolutely. We've journeyed from that microscopic, irreplaceable nephron through the high-stakes hormonal balancing act of RAAS.
And charted the truly devastating systemic impact when that master regulator begins to fail, especially in chronic kidney disease.
We've seen its influence stretch far beyond just fluid balance, impacting red blood cell production via EPO, bone health via vitamin D activation, blood pressure via renin. It truly is the great stabilizer of the entire internal environment.
It really is. So as we close, here's something to think about, a provocative thought building on what we discussed. We spent time detailing that complex, almost catastrophic sequence in chronic kidney disease, the failure to activate vitamin D, the retention of phosphate, the resulting drop in calcium, triggering the parathyroid gland to go into overdrive.
Leading to the body literally stealing calcium from its own bones.
Exactly. Think about that ultimate systemic trade-off. The body, in its desperate attempt to stabilize critical blood chemistry for immediate survival, keeping calcium levels adequate for nerves and muscles right now, will deliberately dismantle its own long-term structural support, the skeleton.
It's a profound example of biological priorities in a crisis.
What does that level of systemic sacrifice tell you about the deep, intricate interconnectedness of all the body's regulatory systems? How trouble in one organ forces devastating choices elsewhere.
It really forces you to appreciate that nothing works in isolation. Every system is part of this interdependent, finely tuned network. Disruption is never truly localized.
A powerful lesson. That's it for this deep dive. We hope you leave with a renewed sense of awe for the sheer chemical power and regulatory genius packed into these two small, absolutely indispensable organs.